Okay, so we're going to discuss methods, research methodology. Okay, we have talked about literature review as the putting together our thoughts, all the evidence we need to establish our position. And then we have gone to chapter 1 to present our opening, our position, to present the theories that we're going to use to investigate. All right. So we have the background to the study. We have the problem statement that identify exactly the problem. Now, note this. Let me ask you this question. We are all familiar with malaria, aren't we? Hello? Are you with me?
Yes, please.
Yes,
please.
Okay, we are all familiar with malaria, and we know that malaria has symptoms, right?
Yes, yes.
Okay. Between malaria symptoms, persistent symptoms of headache, fever, would we say the headache and the fever is a problem?
No.
Why not?
We might treat the headache or the fever, but if we are not destroyed the plasmodium, then we're not solving the problem.
Exactly. So that is why the clinicians will request the lab scientists to check whether the causative agent for that malaria disease, whether it's present in the blood, All these people that keep their microphones down and disturb. Caspar, you're not there, Caspar. Who is Caspar? Caspar, you want me to knock you out of his system? Right, that's why the clinician will request the scientist, please take a look at the blood sample of this candidate. Check for me whether you would find the causative agent, because we know if the causative agent is present in sufficient number, may lead to the disease appearing. One of the signs and symptoms of the disease is persistent headaches and malaise and all of that. We cannot treat because there are other conditions that share such symptoms. So we are not looking at symptoms. The reason why I'm bringing this up is we are not looking at symptoms as the problem. No, the problem is deeper than the symptoms. So we need to do what we call diagnostic analysis to identify what actually is the problem. The symptoms cannot be the problem. The symptoms are just evidence that the problem is present. Poverty is not a problem. Poverty is not the problem. Poverty is only a symptom of a system that is not working well. All right? High level of disease or high prevalence of a particular disease is only a symptom. It's a symptom of an underlying problem. The underlying problem could be a system problem, or it could be the at-risk population problem. For instance, we keep having stroke. All right, stroke comes last. Stroke does not come before hypertension. Stroke does not come before hypertension. When stroke comes in, hypertension had been well established. All right, so stroke is not a problem, but something that had been missed by prevention at the beginning. So we want to see how the entire population is dealing with the prevention issue. That's why public health is a public population thing. So we're not dealing with symptoms. We're dealing with why is it that people are presenting late for cancers, when cancer can be prevented by early diagnosis or detection. So these are some of the things that we should be thinking as public health people when we are asked to deal with it like this. Set up a title, create a title. Start off with the problem. Don't just create a fictitious title that has no problem to solve. You will run into big trouble at the end of the day. All right. So in methodology, quickly, let me see if I can get to my. In methodology, we start with study design. All right. I want to start with study design. There are many study designs. Okay. So I want to use the slide now to help us to see. Okay, I want to speak through these slides so that it makes life easy for us. Okay. All right, so we're going to quickly look at this slide. The slide is on methodology. All right. Okay, so can you see the slide?
Yes, Professor.
Yes, Professor.
Yes, Professor.
Okay, so I'm going to go to the beginning of it. All right, so it has to do with study design. All right, developing methodology and study design. So we have done a lot of groundwork, a lot of analysis, a lot of reviews in establishing the evidence about the nature of a disease in our literature review. That's what the best way I can summarize that. Then we need to begin to interface with readers. Who is going to read my work? Is going to read my work through my introduction. I cannot bring in the literature review before this person. What I can do is summarize the literature review very succinctly and make it our background to the study. I want the person to get the fine part of it to be on the same level as my thinking. That is what background is all about. Bring the person up to speed. Then we now state the problem clearly, not the symptoms. That's why your literature review would have delineated between the symptoms and the problem itself and characterized the problem appropriately. So that in your background to the study, you will probably tell us, okay, this particular TB stuff, this TB, current resistance is not new today. TB has been changing, the bacteria have been changing many years ago, and drugs have been developed to suppress or to reduce the speed with which these microorganisms develop resistance. In fact, if you're going to do some work in TB, there must be a paragraph that will survey or will explain resistance. How do resistance come up in tuberculosis treatment? And what are the mechanisms of resistance? Why this resistance must be there? Okay, so those of you who are interested in TB, remember that. Then the problem itself could be poor use of active drugs that gives the microorganism opportunity to develop new generation of bacteria that destroys the drug that should destroy them. That's one reason. And in what way do we give opportunity to microorganisms to develop resistance? Either we're not using the drugs very well, we're not using it Sometimes self-medication could be the reason. All right, so these are all human behavioral issues. So once it's human behavioral issues are identified, then we want to look at the antecedents. Right, so this is what we have established in our literature review. Then we go on to the problem statement, then questions raised. There are many questions raised that needs to guide the rest of the study. We've all done that. Then when we get to the objectives is what will now feed into our literature methodology. It will determine the type of design. So here we have design approaches. We have a quantitative approach. We have qualitative approaches. So these two approaches are very unique in research methodology. So we now have other approaches that can be either quantitative or qualitative because they are reviews, systematic reviews. So we have quantitative approach, we have qualitative approach, and they are different. They provide different perspectives and they provide understanding that, complement each other. Quantitative, you are counting, you are measuring. Qualitative, you are comparing and you are defining and explaining perspectives. So in research design, we have generally, in research, they have experimental and non-experimental. There are two categories of design approach, so there is a difference between categories of design and approaches. So approaches, you can approach the research by quantitative approach, or you can approach it by qualitative. All right, we'll explain that. But the study design generally are in two categories, experimental and non-experimental. All right, so quantitative, they are like measurement, you're conducting measurements. All right, so you're conducting measurement, you're taking a sample from a population to test the impact of the treatment. That is what we call intervention, experimental. All right, and then you want to control other confounders so that you are sure that whatever treatment that is applied in an experimental is working. Quantitative simply means we are quantifying. We are quantifying. So if we are quantifying attitudes, quantifying knowledge, quantifying outcomes, all of these. Patrick, you are distracting us. Patrick. Okay, so in the approach of quantitative, we have experimental design. We also have quasi-experimental design. So when we talk about experimental design in our domain is public health system. In the health system, the best and the highest quality of research is done with the experimental. There's a reason for that. And the clinical study is the experimental design that provides us with the highest quality of research, which we call the randomized controlled trial, RCT. Now, this represents the gold standard in study design for us in the health system, whether public health or clinical health. It beats everything. All right, so I want you to take that in mind and go and look it up. Then the next one that follows, this is the one that public health research follows. The public health research follows the quasi-experimental design. And the reason is that the rigor involved in developing quasi-experimental is not as deep It's not as deep and extensive as the randomized controlled trial. So the randomized controlled trial is very rigorous to be sure nothing else is influencing our result. And this is the method by which the vaccines, drugs have been developed over the years. Drugs and vaccines have been developed under the randomized controlled trial for decades. In the early 60s, randomized controlled trials were not used. They were just simple experimental. But after some problems were discovered in the production of drugs, a new method was introduced called the randomized controlled trial. Very rigorous. That's why we designate it as the gold standard. Gold standard means that every other research every other standard will be compared to it. Every other, it's the number one. Jacqueline, your microphone is off. Okay. So, so for public health, because of the rigor involved and what we can do and what we cannot do with human participants, quasi-experimental design is used in addressing health challenges in public health. Okay, it has limited rigor in the development of the treatment protocol as well as in applying this implementation of that treatment. Different. So I want you to go individually, look at what those two they look like. What are they? Find out what they are. I don't want to mention, start breaking it down, but you're old enough to go and look them up. Or you can go to PubMed. Go to PubMed, type in randomized controlled trial, pick 2. Then type in quasi-experimental design, pick 2. The study that we published recently that came out yesterday is a quasi-experimental design. You can look at it. You can look at it. It's well designed. We designed it very well and implemented it very well with all the ethical restrictions and so on. All right. So characteristics of randomized controlled trial is that the population, the participants are randomized. All right. Randomization means you are assigning these people, all right, to different groups. You have control, you have experimental group. So you are now randomizing them. You give them numbers 1, 2, 1, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. When you've given everybody, maybe they picked in a box all the participants after consent to participate. Then you now ask them to go and pick from a box. The box has papers written 1, 2, 1, 2, 1, 2. Okay, so they are now picking and going, picking and going, picking and going. Equal number of 1, equal number of 2. So each person can pick and go. Whatever you get, you go to the side. You get 1, you go to one side. You get 2, you go to the other side. Right? So at the end of the day, they will be equal. That 21, 22. So you now probably ballot that 1, 2 will be experimental and 1 will be control. So whichever, like the football, when they are going to play football, the captains are called by the referee and they toss a coin. They will now pick head or tail and they toss the coin. Whichever comes first will pick. So we have randomized them into control and experimental group. The experimental group will receive the treatment. The control will receive nothing or an equivalent, but not the same as the experimental group. And in clinical, it's easy. They've done the randomization, but in quasi-experimental, you can't do that. You can't do that for human beings. Well, you can do that for location. Maybe you say, okay, regions in Uganda, There are regions in Uganda. You can now say, okay, we'll pick one region to be controlled, one region to be experimental group, and so on. But there is limited you can do for quasi-experimental. Then we have control. Yes, experimental has experimental and control. Likewise, quasi-experimental has both control and treatment group. Now, what makes the difference for randomized control is that you can manipulate the amount of treatment. All right, so if it's a drug discovery or drug development, you can want to find out which dose produces the best effect of that drug. So you can now put different dosages that will be administered to the candidates, and the effect of the outcome of the drug or the effect of the drug is measured. But you can't do that for quasi-experimental because it's one treatment. But in randomized control, the dosages represent the varieties of the treatment that is given. So the treatment is administered once for quasi-experimental, whereas the randomized controlled trial, the treatment can have different dosages. All right, but now we are developing something that closely approximates those dosages for randomized control. We are approximating it by developing arms. Instead of one treatment arm, we can have 3 treatment arms and a control. That's 4 groups. 3 treatment arms and a control. All right, we are developing that now so that we can close the gap. We can close the gap between quasi-experimental and the quasi-experimental and the randomized controlled trial. So the analysis, the method of analysis is also different. So we have blinding, crossover. All these are for randomized controlled trial. So we can compare pre and post for both quasi and the randomized controlled trial. We have non-experimental design. Most of the non-experimental design, we call them observational studies. They could be in the epidemiological, they could be in the public health. All right, so generally non-experimental means that you're not changing anything. You're only observing. That's why we call it observational studies. You have typical of cross-sectional studies, typical of observational non-experimental design. Okay, you can have cohort groups, cohort studies, case control, and all of that. They are just they are just observational. All right, so a survey design provides a quantitative or numeric description of trends, attitudinal disposition, opinions of population by studying a sample of the population. All right, so I've sent you a video on the philosophy of research. I sent you a video on that, but I don't. Did you see the video? Anybody?
Yes.
Yeah, okay. It's there on your Telegram. It's also there in your Planet. So typically, cross-sectional studies are usually referred to as prevalence study because at the end of it, we are mentioning the disease or the condition of the disease or the behavior that brings about the disease as the outcome, and we are counting, call it prevalence. And this also demonstrates relationship and may be primary research or implementation research. So the observational researches are usually the ones that help to uncover dynamics. I don't know if you know what diagnostic is. can you remember the video on KAP diagnostics? You need to go back and look at those things again.
Yes.
All right? So go and study them. There's lots of things that you can learn from those videos. There are many things which this class cannot hold. All right, so we have qualitative now. We're looking at qualitative study design. These are also non-experimental design. They include aspects of discussion. The main philosophy of qualitative is to identify answers to questions quantitative cannot provide clear understanding. So the qualitative design seeks to identify perspectives. It's important that we understand that. They seek to identify perspectives and reasons for the occurrence of problem phenomenon in a community or in a population. Quantitative may not be able to fine-tune into. So we now use qualitative to make up the weaknesses in quantitative. Please note that. That's what we mean by mixed studies, mixed methods, right? So in mixed methods, we can use the qualitative first to understand so many things about the disease or the condition that the research is going to, address. We may want to find out what do the community of people, the population, what do they think about this disease? How do they visualize it? How do they interpret the symptoms of that disease? It's important. Some of the symptoms manifestation have cultural connotations and implications different from scientific. Imagine. So the qualitative initially will help us so that when we now create our instrument will be culturally competent to elicit. Did you understand what I mean by culturally competent? I mean, you are not writing like a scientist. They will not understand it. So you go first to them and ask them in your culture, in your language, what do you mean by this? How do you describe this? So that when you put that in the questionnaire, your candidate, your participant will understand what they're talking about and give you correct response. That is one way of using qualitative. Another way of using qualitative is, okay, now we have done some analysis and we have found some things. So we now go back to the community of those people and ask them, why is it that they responded this way? Those are questions we cannot put in our questionnaire. So we have done the questionnaire aspect, we've done the analysis, we've discovered some things that are strange. They're not like expected in, So we go back to the community with a qualitative to identify the perspective of what we found. Where is this thing now? Somebody has. Okay. So we now find out through focus group, key informant interviews, and in-depth interviews. So what are these methods? Focus group, I will describe focus group quickly. Focus group is a group of individuals between 5 and 10. You can have 5 people, 6, I would like that, up to 10. They come together, they are the same. So that's why it's called focus. So their discussion will be focused. Are you listening or you're talking to yourself? So the focus group is done by collecting 5 individuals minimum. Then you will be the researcher will be maybe just inspecting, and then appoint a moderator, somebody who will moderate. Then there will be a secretary that will be writing down what they're saying, and then you probably will record it. You have an audio record or even video, but before you use that, you will seek permission from them for the purpose of accurate record of what has been. All right, so that's focus. Then you develop a focus group discussion agenda. Okay, so that will help to focus your discussion. It won't be an open discussion that will trail away from the focus. So it's focused on the particular thing that you're trying to find out why, reasons why. You're not asking them, are you aware of? They say yes. No, questions that you ask, they are not really questions that will have answers yes or no. Please note that. They are matters. There are matters, topics that will be discussed that needs explanation to respond to. Okay? Questions like, why do people from this side prefer this? They will explain. Okay, so the explanation is what you are looking for. Okay, so that's focus group. At the end of the day, you will now translate or transcribe the comments into one place so that you can see them, and then you do the analysis, thematic analysis. You can also have what we call key informant interviews, KII. Now, this key informant means people who are special, people who are concerned, they are in the middle, they're key, they are important elements in that condition. So these key informants, you will talk with them. All right, you bring a interview guide, develop one, then you use that interview guide to find out deep information. Then you have in-depth interviews. In-depth interviews and key informant, they overlap. All right, they overlap. All right, so that is what we mean. In the analysis of this type of research, there are no numerical analysis involved. There are no numerical, no mean, no nothing, no percentage. All you need is reason why something happened. So we start off by categorizing themes, but it's always good to have a focus where you are going, so that the information you have will not be too much for you to categorize them into themes. All right, so you categorize the discussion, the answers into themes and sub-themes, because the sub-themes will come out from the themes, the major themes. Themes are subject areas, topics, subtopics, those are themes. So you now go down to sub-themes, and then you now start to have a picture of what is going on. All right, so the types of research, I'll quickly open up. So you have 2 major types: experimental on the left, randomized controlled trial, and quasi-experimental on the right, on the left. On the right, you have non-experimental observational. These are observations. So the ones on the left will change something. So the title, the sample size, everything about the experimental is different from non-experimental. So if you're doing an experimental design and one is expecting you to do it as if it's observational, it's wrong. The experimental design is focused on the treatment, whereas the non-experimental design is focused on the sample's ability to approximate the population from which the sample is drawn. You see that the 2 of them are different. They are different. Okay. I've sent you a video before of this, what I'm talking about. So go back to that video. You will find it. Then we have under non-experimental observational, you have the longitudinal. All right, on the longitudinal, you have the prospective and retrospective. Prospective, retrospective, longitudinal, these are two epidemiological studies, either as cohort or case control. Retrospective, going back, we want to see what the beginning of a disease caused. What was the beginning of a disease cause to bring it to what it is today. Prospective, you start with today and see how people are exposed to a particular risk factor and how they end up. And a prospective can take up to 5 years, 10 years, 12 years to conclude. So under cross-sectional, you have the surveys. All right, you have the surveys and interviews. All right, so these are the designs. Okay, so this is for another day. We have done study design. We're going to look at sample size determination next week. Okay, any issues before I say bye-bye? Hello? No issues? Okay.
Excuse me.
All right, I see 2 hands up. William. After William, we'll go to Ambrose. After William. All right,
Thank
William,
you so much.
you're welcome.
Okay. So my query is, of the two designs, how do I tell whether I'm going to use a qualitative or quantitative study? And secondly, in qualitative, how do I determine whether to do a key informant interview?
It's your choice. It's your
discussion.
choice. It's your choice. For you to do qualitative alone will be very rigorous. For you to do qualitative alone, you need to do about 20 interviews, 20 key informant interviews with focus group. It's very rigorous, and interpretation and data collection is very rigorous. All right. So the best thing is to do a mixed method. Focus heavily on quantitative and use qualitative to make up where the quantitative is deficient. For instance, you want to find out why. Your quantitative cannot find out why easily, except you use models, where the models will guide you in developing your instrument. Okay, so most people are not familiar with how to use models. Then if you are doing qualitative, focus group has more people in it at a time, more participants at a time. If you're doing key informant, only few. For instance, now, if you are doing a study on satisfaction of TB patients attending health system or health facility, all right? You can do you can do both. You can do quantitative, qualitative. For the patients, you can do quantitative with them, and then you will do qualitative with the staff, the workers there. All right, and you choose different categories: the worker, the supervisor, and then the managers. All right, because you would take probably two or three, but the survey will be like the patients. You want to find out so many things about their susceptibility to the condition. All right, so that's where you can choose. All right, let me do a key informant here, or a the key informant, or an in-depth to be one person. Two will be better. But the other one that has survey, like patients, we want to find out knowledge, attitude, and perception of the patient concerning the health situation. All right, so that's how you do that. Okay, so that's Ambrose.
Yes, thank you, Professor. I don't know if I'm audible.
You are very audible. Can hear you well.
Yes. For me, I just wanted clarity on two issues. The first one is on the difference between an approach, a design, and methods. Because when we are reading the literature, some are looking at the approach, they say quantitative, qualitative, but others you find they are calling them designs. They are saying what is the research design, is qualitative, quantitative. Then also when they talk about methods, some literature still talk about qualitative, quantitative, some adding some cross-sectional. So I wanted a clarity on that. Then the second one is on the clear cut between the quantitative and qualitative. Because, for example, if you are doing a focus group or key informants, sometimes you come in with a structured questionnaire. Now, the questionnaire is collecting quantitative data, but the method looks at it falls under qualitative. So I just want clarity on those few issues.
Okay.
Over to you, Professor.
Yeah, I'll take the last one first. I can remember that now. Now, when you're doing key informant interview, it's not questionnaire you are developing. All right? Because in that data collection, you are not asking question like you are asking question in the questionnaire. What you are having is key informant or in-depth interview guide. It's only a guide. Do you get it? Because the interview is discussion. You are discussing. So it's not the same as a questionnaire for collecting quantitative data. You are giving the person opportunity to discuss freely. So you have a guide. All right? The statement in your guide is what starts the conversation. It begins the conversation. So what you have for interview guide, focus group guide, key informant, they're all guides. Statements that will pick up. Okay, let me show you a typical one. I used it for my PhD work. All right, let me just quickly find it now. Okay, document. So I'll show you what it looks like. All right. Okay, you can see this now, can't you? Can you see Appendix 3?
No, we can't see, Professor.
From my side, no.
Okay, let me reshare that. Sorry. Okay. All right, so this is what a typical focus group discussion guide looks like. All right, it starts with agenda for the discussion. It's a discussion, not a questionnaire. Discussion of major themes around the issue of treatment adherence in hypertension with regards to knowledge, perception, blah, blah, blah. Okay, so there is a beginning. All right, it says the aim of this focus group is to uncover the experience. So we're looking for the experience of the participants, their views, interpretation of events related to the disease condition and treatment by participants, okay? So we start off with, this is a guide. So it's not like questionnaire. There are preliminaries. So the preliminary starts with, it describes what the moderator, this is a report, it describes what the moderator will do. So if I give this guide to somebody, the person will just follow this and will do exactly. All right. So moderator greets the participant warmly. So the moderator would sit down and greet. Then the next, it proceeds to explain the purpose of the group discussion. Will now tell them. All right. So that they become well acquainted with the with certain issues surrounding their, all that. The moderator seeks permission. So the moderator will now ask permission to record the discussion on tape for validating what the secretary has recorded on paper. And now we will urge all the participants to respond freely in the discussion. So it will now assure them that they can talk, they can speak up, nobody is going to hold it upon them. The moderator initiates self-introduction and encourage participants to introduce themselves as well. All right, so that part, the preliminary is gone. Now the moderator will now come into the preamble. This is the preamble to open up that discussion. So the preamble includes what the moderator will now ask this question: what has been the challenges since condition was diagnosed? So this is particularly to the study I did. So these people were people coming for treatment for high blood pressure. So the question, and they participated in a program which I initiated. So it will ask them, I asked them, what has been the challenges since the condition that they are in was diagnosed? All right. So they will speak, everybody will speak. When they are finished speaking, if I feel there is need for more discussion, then this particular part says probe further. Probe further is the person will ask more questions. If you remember, some interviewers on TV, CNN and all that, Al Jazeera, when they are interviewing people, they will ask a question and the person will answer. They will ask another one and another one and another one until that subject is exhausted. So that is what the probe is. So the probe here says, are there any expectations since treatment began? The person will now explain. So we would not use questions that you have yes or no answer. So the questions you put are questions that will stimulate a discussion or an explanation. We record that. So the next probe will be, how far have these expectations been realized? Then the next one, do you think that this condition is curable? That's hypertension. So they will answer. Then you go further. What types of drugs were prescribed? So you see, it's not like a questionnaire. It opens up discussion, open-ended. Okay? So even there, after this first probe, you can still probe further. For what reasons were these drugs given to you? See? So there, probe until when you are sure that you have finished, we have finished that theme. All right, you can start another theme if you have, depending on how many. All right. Okay. Now we have in-depth. This is another typical in-depth interview guide. So this is an in-depth interview guide. You put the particulars of the person who is interviewing and the person who is being interviewed. All right. So you also start with introduction. Thank you for agreeing to be interviewed. Your assistance and commitment are valuable and important. You just introduce yourself and then you start. The aim of this interview, you explain it to the person, the purpose of the interview, you explain it. Then the procedure, you begin. This interview will last about 30 to 45 minutes. All right, I will be taking note of, you just explain the procedure to the person. Now, after that, the bracket here says, thank the key informant for giving consent to do this interview. And so because when you take this guide and give it to anybody, you will do it exactly as everybody will do it to get the same result. Right, so the first question comes. Please kindly tell me what health condition brought you to this health center. You see how this particular one, how that particular question fall in line with this particular question here. What have been the challenges since the condition was diagnosed? All right. Are there any expectation? Blah blah blah. All of these now will corroborate, but because this in-depth interview is for the client themselves, the client. So we have key informant for support individual, a significant order. So again, we want to confirm everything from every angle. Okay. So after saying, please kindly tell me what health condition brought you to this health center, the person will explain. Then you will now probe further. How long have you had this condition? The person will now answer. Then you kindly describe what happens whenever you are here at the outpatient facility on a daily basis. They will explain. So you continue like that, probe until you finish. All right? So that is the typical. Now this is for social support, the same. You have, okay? Please kindly tell me why you are involved with the care of the patient. This is for the key support, the person who is supporting. All right, who is the patient? You, and how long have you been involved with condition? Blah blah blah. Rosa, microphone is off. Okay, so that is the type of. Now this is the one for the supervisor. So you have that's why they're called key informants. There are specific people that have understanding or know something about the situation. All right. So now I've shown you the instrument. Let me show you how the data is reported in the data is reported here in a peculiar way. So in the discussion, we use the data together. All right. So this is typical of the data used. So this is the discussion. So the data is used here, you see. the data is used to support the observation. So it starts on here, reflecting on the program. This is me now, reporting, reflecting on the program during the key informant interviews, 12 months after follow-up. Some of the participants stated that all they needed was someone to explain clearly the far-reaching implications of their condition. So what I'm writing now is I'm trying to get everything that I've put here. Then I'm putting them together, but I need here specific tone and voice of those people to corroborate what I've put in here. All right. So here we say the responses from these participants are a demonstration of the value of a structured health education and counseling on outcome of hypertension treatment. So this is the direct speech. We call it I just flown away. It's a quotation. We call it memorable quote. So this is a quotation from female patient. We did not put names. We can give codes. Female, this is patient, female, like. So the female quotation that supports this says, able to understand how the medication can control blood pressure and what can happen to a person who is not taking the medication regularly. I think the program was useful. All right. So this is a statement from somebody, and all this in italics represent statements from individuals. All right. Like that. Continue. Okay. So that is what we mean by key informant, the qualitative. So that's what mixed method is. All right. So I'll see Margaret. Your hand is up since. Margaret. Quickly.
Yeah, thank you, Prof. Mine is very simple. I have issues with my title, so I was requesting if I can talk with you bilaterally for support, for assistance. I don't have your... Sorry. I'm requesting for your WhatsApp number.
Okay. All right. The Telegram number is my WhatsApp number.
Okay, thank you, Prof.
Yeah, my Telegram number is my WhatsApp number, okay? Very good.
Thank you, Professor. There was the first question.
Yes, that was the first question. Remind me the first one. This was the second question because it's fresh in my mind. So what's the first one first?
The first one was about the designs, approach, and methods.
Yeah, they are all semantics. They are just... When you say methodology, okay? When you use the word method is not the design, all right? Method is not the design. Method is everything you are going to do to get an answer to the question you raised, all right? So sometimes we say methodology or we say method. Method will include what design are you going to use? How are you going to get the people? What criteria do you set? What are your hypotheses to be tested? How do you develop your instrument to measure? How do you validate it? How do you do the analysis and the ethical issues? Those are methods. All combined, they are methodology. Okay? But when you talk about study design covers whether you are doing an approach that experimental or non-experimental, or qualitative or quantitative. Those are approaches. If it is quantitative, what design is it? Did you get that? If it is quantitative approach, what is the design? Quantitative is not a design, it's an approach. Qualitative is not a design, it's an approach. The approach is qualitative. So what is the design? Key informant. The approach is qualitative. What is the design? Focus group is the design. Okay, the qualitative is approach is quantitative. What is the design? Cross-sectional observational study, or cross-sectional study, or cohort study, or prospective or retrospective design. All right, so those are the things we use. Okay.
Yes, thank you, Professor.
Just like many people, when they have, if you look at sample size, we will do sample size determination next week. All right, so I want to just quickly identify what we have covered. We have covered how to develop the literature review. We have covered what it takes to develop the chapter 1 of the study, which is the presentation of the researcher's position, okay, and to prove his point. Then we are touching on the research methodology now, the methodology, the method. So we have introduced the study design. We have introduced the approaches and study design. All right. Next week, we're going to talk about the population. So the population, we cannot take everybody. All right. We cannot take everybody in the study. So we need to set up criteria, and then we need to identify the appropriate sample size. This is an area that is confusing to many people. And there are many things that are wrongly done by scholars, which we need to get right. So next week, we're going to get everything correctly, how it's supposed to be. Yeah. All right. Okay. I think our time is up. We have 4 minutes to go for the next class to join us. Yes, Mariam. Oh, you're waving. Okay. All right. Thank you so much, everyone. I think today's have been very, very helpful. Please go and read that article I posted. Oh, it will give you some, particularly the sample size determination. Please go and read that section. Download it. It's free. You don't pay anything. It's open access. All right. So download it and read it. You will gain a lot in the packaging. You see the packaging of the whole thing from introduction down, even the discussion and the conclusion. And the apps, all of them are, I usually tell my students that particular paper is, take it as ideal. All right. Though it's an intervention, you will see how the results and the conclusion, the conclusion comes from the results. All right. Thank you very much for being here today. And yes.
Victor here.
Yes, Victor.
I have the same concern like Margaret, because I submitted my title to coordinator on impact of socioeconomic factors on tuberculosis treatment.
Yeah.
But from this discussion, this discussion is not the right thing.
Yes, it's not correct. So, it's not appropriate.
What is your advice on this?
You change it. It doesn't have to be there. Remember, it's your pilot study. You can't find out impact unless you are doing an experimental study. All right, let me explain something about impact. Okay. Now let's imagine a car driving, or no, let's imagine somebody jumped from a second floor building. Somebody jumped.
Good afternoon, members.
Yes.
Good afternoon.
We are hearing you.
We are getting you.
Speak up.
Hello?
Speak up.
We are getting you, please.
Hi, how are you? Good afternoon.
Good afternoon.
Good afternoon.
Are we really using the right link?
I'm not really sure. I thought this is the one we've been using before, unless it has changed today.
Okay.
I'm not, I don't
Because
understand.
no one is saying whether the professor is coming or
Can you explain
is there
yourself,
any communication from him?
or you are discussing with
No, I
somebody else?
haven't seen one. Also on the WhatsApp page, there is no communication.
Hello, speak up. We don't know what you're talking about.
Okay, thanks.
Oh, seriously. Okay, as I was explaining, somebody jumps from the second floor of a building and lands on the ground. What would you call that? Would you call that outcome, or would you call it impact?
I think it's an outcome.
No, it can't be outcome. It's an
Impact.
Impact.
Of course,
An
you're
impact.
impacted. An impact is an immediate result of an action. Okay? So the person fell down, boom. The impact of that fall caused fracture. Okay? Immediate change that takes place is an impact. Fracture of the limbs, probably other parts. And the person now is taken to the hospital. Okay? And the person was put in cast, and for some time, the person's health started to deteriorate, and the person died. What would be the outcome of that fall? Death. He died.
It is death.
It is
Death.
death.
Death is the outcome. Impact is the fracture. Probably the fracture caused internal infection of the body or the blood that caused the mismanagement of the case, and the person died. Now, if he did not have that fall, the death would not have come. You get it? So that's what sometimes there's a mix-up about this thing, impact, outcome, and then people use it in research. You can't use it in research except it is what do you call it? Experimental or intervention, because something is happening. Right. So I think the people coming in from health promotion are already coming in. So thank you so much. We can disengage and get them in. All right. I'm going to close down.
Professor, I will engage you privately as well.
Please do.
Victor.
Yeah, please do. All right, so that the rest can come. All right. Thank you so much. Have a wonderful.
Thank you, Professor.
Yes. Have a wonderful week ahead. So
Thank you, Professor.
You're welcome. So I'm closing this now, and
thanks, Prof.
You're welcome, and welcoming the others as they enter. All right. Thank you.